Okay, so good afternoon. I think we can start. We can not continue to wait for other people. So, do you see the screen?
Yes.
Yes. Okay, thank you. So this afternoon we shall cover this chapter on disorders of saturation or hemodynamic disorders. So the learning objectives here will describe features such as edema, heart failure, liver failure, kidney failure. Edema as seen in inflammation, heart failure, liver failure, kidney failure, and the other conditions. Also, we'll see the causes and the consequences of hemorrhages, the virtual triad, as which are the causes of thrombosis. We also look at the shock and describe the problem of whole body hypoperfusion, which just is the same as a shock. And also we see the physiology and the types of the shock. So that's in summary what we shall see. But also the other minor things such as the infarction and so on. So the saturatory disorders, they can be due to defects in the blood vessel. BV here refers to blood vessel. And these problems may be associated to narrowing of the caliber of the lumen, the rupture of the vascular wall, or the aneurysm. So aneurysm, it is an incomplete rupture of the wall whereby there is a secondary pocket. There is a secondary pocket which is created within or inside the vascular wall itself. So that's called aneurysm. So secondly, we shall see thrombosis. It just means coagulation or clotting of the blood inside a blood vessel or inside the heart. Embolism refers now to anything which can occlude vessels and especially arteries. The venous congestion and arterial hyperemia, we shall see it. We start, actually, it is one of the first case we shall see here. Then edema, shock, and okay, there are these saturatory disorders that we look at. So, as I said, we'll start with hyperemia and congestions. These are basically almost the same things, but pathophysiology and clinical appearance, they completely differ. They are opposed to each other. So both of them, they refer to the stagnation of the blood inside and within an area. So refer to more blood within a vascular compartment of a tissue than in a normal state. So the main difference is that hyperemia, which is called also active hyperemia, it is when that blood is increased in blood volume is seen at the arteriolar end or at the artery end, while congestion, it appears at the side of veins. So that is the main difference. And here you can understand that for hyperemia, there is occlusion. Usually there is an occlusion somewhere within arteries or arterioles. While congestion, there is something which prevents the blood to return to the heart. So in that case, the blood will be stagnant inside the venous system. So that is the main difference. So the picture here explains it all. So here there is an increased inflow of the blood. This can happen if there is an inflammation, so they should have put a double M, or intense exercises. So here you see that even the caliber has increased in size, it has increased as a defense mechanism because of the increase in the volume of the blood. But the outflow at the venular end, it didn't increase. So that means that the blood will continue to be in high quantities or volume in that arterial end, or at the venular end, the blood which lives here will be just in normal quantities. So for the congestion, it is the opposite. The opposite. So what happens? The outflow is decreased. Hyperemia, there is increased inflow, but the blood leaving is not increased. So here there is a continuous increase in the volume. While for the congestion, because of the decrease, the outflow, maybe because there is something occurring here, which can be parasite like filariasis, elephantiasis, there is an occlusion of vessels by parasites. So in that case, there's usually lymphatics, but lymphatics and the veins, they almost do the same thing. So in such cases, the blood will not return very easily, therefore it will be stagnant somewhere, and as a consequence, there will be swelling. But when clinically look at the area, if it is a clean skin, not a clear skin, you will see that the area is bluish when it is congestion. While when it is hyperemia, it will be reddish because the blood here is oxygenated, here the blood is less oxygenated. So here, the signs that we see here, the causes are obstruction or congestive heart failure. So the heart cannot allow the blood to come back into the right ventricle in adequate quantity. While here the causes, as I said, they are exercise, inflammation, and so on. So a hyperemia is called also sometimes erythema, and this is a term that you will see being used mainly in dermatology. It is very important to know these terms in dermatology because knowing how to call the signs, it helps much in determining the disease and therefore treat it. While in congestion, there is a cyanosis. Cyanosis means decrease in the oxygen within the blood, or hypoxia, almost the same. So that's all for hyperemia and the congestion. So hoping that if you find someone with one of these problems, then they tell you to examine and give the diagnosis, you will be able to say this is hyperemia or this is congestion. And then if it is congestion, you will know what are the possible causes. Is this patient having a cardiac failure or congestion, or is there an obstruction at the venular end somewhere, maybe caused by cancers or other things, and so on. If it is hyperemia, is there intense exercises, is there intense inflammation? So you understand that depending on what you have defined, if you have concluded this is hyperemia, automatically you go to the inflammation, exercise, and so on. If you have said it is a congestion, then you must, the possible diagnosis will be heart failure or congestion or obstruction at the venular part of the circulatory system. So we go to hemorrhage. So there are terms. These terms are very, very important to know how they differentiate, because as the doctors, you will be responsible for doing examination of live people, but also dead people. So this is important in dead people, because if you examine someone who has purpura, and he said he has petechiae in forensics, it will be like a crime. Because, for example, if someone is having a conjunctival petechiae, there are reasons, possible reasons. If it is purpura, there are other reasons. So this means that you can say this one is having purpura, while it was petechiae, and petechiae, we refer that he was strangulated by people. While for purpura, it can be caused by other things such as severe infection with shock. So if there is a dead body then and you give a wrong description, it will mislead the police or investigators and many other consequences. So that's why you have to be very careful with this term. So the main difference, petechiae, they are pinpoint hemorrhages that involve skin, mucous membrane, and the serous surface. So they are very small, pinpoint. Nukuva ahantu hameze nk'awagira mu dushinja rw'igikwasi. Barute hemorrhage duto cyane. Purpura, they are larger skin hemorrhages which can go up to 1 centimeter. Yes, if it is more than 1 centimeter, then it is no longer purpura. It can be something else, like ecchymosis. That it is called sometimes a bruise. So in most of books in English they use bruise. So hematoma now, it is a collection of blood resulting from hemorrhage. So the difference is that this hematoma, it is something you can do incision and remove that whole volume of the blood. So it forms something like a mass, like a cyst. While for ecchymosis, you see hemorrhage, but you cannot do surgery and they remove the blood because they are infiltrating tissues. While in hematoma, there is a pocket of pure blood. So hemorrhage into the cavities, we will not talk much about them. You will see them in different fields of surgery and internal medicine or pediatrics. So, but here you have to know these terms. Hemothorax. Hemo means blood. Thorax means the thoracic cavity here. So it means there is a collection of blood or hemorrhage inside the thoracic cavity. Hemopericardium, there is hemorrhage within the pericardial sac. You know, these membranes, they are always two, visceral and parietal. So between them, there is a cavity. That cavity usually contains a small volume of fluid, which serves as a lubricant there. So niba ari umutima kugira ngo mu gihe uri kubyina utera kugira ngo utere very easily nuko inyuma yawo haba hari ahantu hari hanyerera. So that's why there is that small quantity of fluid between visceral pericardium, which is directly attached to the heart itself, and the parietal pericardium, which is now not attached to the heart. So hemoperitoneum, the same, the hemorrhage inside the peritoneal cavity. Hemoarthrosis, there's hemorrhage inside the joint cavity. So these are the terms that we have. So there are causes of these, but most of the causes here, they are traumatism. So purpura, as we remember, purpura is larger than petechiae. So purpura, you see that there are large hemorrhage lesions. So it is not pinpoint, they are large, as you can see, they are somehow large, and there are many. And there are many reasons for this. So it is characterized by hemorrhage into the skin. The appearance varies depending on the type of purpura, the duration for the lesion, and the acuteness of the onset. So first of all, when the blood goes out from the blood vessel, it is red, but gradually it becomes purple, itangira kuba brown. So you know that because it is losing oxygen. So after that, it becomes yellowish. Why? Because you know in blood there is heme, of course, the hemoglobin and so on. So it will be catabolized to give rise to things like a bilirubin, which is yellow. That's why it becomes yellow. And then after 2 or 3 weeks, everything will disappear if the hemorrhage was stopped on day 0. And the color depends largely on the type of inabsorbed pigment of the extravasated blood. So this is what I was explaining. So if there's bilirubin, if it is not yet bilirubin, so the color depends on this. So these also are very important. In a forensic, as I said, in forensic, if there is a dead body, the police brings the dead body to the hospital where you will be working. They want to know the cause of death. Of course, sometimes you can't find the cause, but at least you must describe and say, maybe because I see that the blood, the purpura is still red, so it means this person died just or got the purpura and automatically died, or he died when he had the purpura, a fresh purpura. But if it is purple, it means there has been a time between death and the occurrence of the purpura. If it is yellow, it means there are some days, because that purpura had the time to be transformed into a bilirubin and so on. So this will help in terms of calculating the timeline of the death of that person. So ecchymosis, you see, or blues, how it is secondary to a trauma. So you see that there is a hemorrhage, but it is not a hemorrhage that you can do operation on and remove blood. It is not possible, because they are just a hemorrhage within the tissues inside the skin. So petechio hemorrhages, they are seen in mucosas. They can be seen usually on conjunctiva. So they are very small, very small. And I remember when I was in the district hospital, we used to have typhoid. So one of the signs of typhoid wasanga umuntu afite petechio hemorrhages kunda agana hasi. So it was a sign which was known to be associated with typhoid fever. Although I don't know the mechanism, but it was known. So it seems nowadays that sign is not seen. Probably there are things which have changed in the pathophysiology of the disease. Probably we have a new strains or variants of the bacteria causing typhoid fever. So here we have fatal, means it causes the death. Intracerebral hemorrhage with large hematoma. So hematoma now here, you see that you can do surgery and remove this blackish region. This is a collection of blood. It has become black because the hemorrhage stayed there for a long time. So usually when a patient has things like this, he starts or she starts having neurological deficit. Ukabona atangiye kugira nka paralize uruhande rumwe cyangwa akaguru cyangwa akaboko cyangwa uruhande rumwe rwo mu maso, depending on which site of the brain was affected. And if you order an X-ray or a CT scan and they find this, then they will do surgery to remove this intracerebral hemorrhage with hematoma. But there are times we have hemorrhage which just infiltrating different areas of a tissue. In that case, you cannot do surgery. You can just treat it using a medical procedures, meaning drugs and so on. So what is the clinical evolution of a bluish? So it begins as a blue-black abnormality, becomes orange-yellow over several weeks. This is a bluish. You remember what I presented before? It was a purpura. So here it takes several weeks to become yellow. While for purpura, it takes a few days to become yellow. This is because in purpura, there are small hemorrhages. So the changes, they can appear very easily. While in a bluish, because it is large, to have a change of color of the whole mass or of the whole region, it takes time. So gradually there is a resolution of the orange yellow color and it returns to normal color. So this is clinically what you can see. So yeah, again, coming back to the trauma, even outside the autopsies, ushobora kwakira umurwayi akakubwira ko avuye mu biro bya gitifu w'umurenge kandi ko gitifu w'umurenge amukubise akakwereka aho hantu ukabona ni bruise. So RIB ikabizamo as a medical doctor will help. So if you find that there is a change in the color and the bruise is becoming yellow, you will know this cannot be a traumatism of that day or of a few days or 1 week. It is a traumatism which has been there for a long time. So therefore you can rescue that person who was alleged to have committed such an act. So histologic evolution of a bruise, so maybe you don't need this because this is just a histology, but here it is to show that the changes you see clinically, they have their histological basis. So what happens inside there? So we have, for example, as I said, when there is a blood, there is a bleeding. So when there is a blood which is outside the blood vessel, the monocytes or macrophages, they will migrate to go there to clear that space, that area from the hemorrhage. So when the monocytes become activated, they are called histiocytes or macrophages. So these macrophages, they will make sure the red blood cells are released or they are destroyed. When they are destroyed, their hemoglobin will be broken into heme and globin. After that, the heme itself, as I said, will be converted into hemosiderin, which is the orange. You understand now where the orange color comes from. So this is the hemosiderin. So after time, then this hemosiderin will become we have many intermediate steps such as bilirubin and so on until we have bilirubin. So that's how the color changes. Yellow is usually bilirubin. So that's all. So it is for you to understand why the color changes clinically. It is because of the histologic changes. So that's for hemorrhage itself. So if no question, we go to the thrombosis. Okay, we proceed, no question. So thrombosis just means there is a coagulation inside the blood vessel. Normally this should not happen. So the way we are created, this normally cannot happen. To have a blood clot inside a blood vessel. A blood clot can come when there is an injury, but that clot will not be inside the lumen. It is usually inside the wall of the lumen. And when, in that case, when even that clot is made just to contain the hemorrhage, to stop the hemorrhage, when the hemorrhage is completely contained, then the body has a system to destroy the blood clots. Because blood clots, they are very dangerous, as we shall see. So, to have a thrombosis, thrombosis itself is intravascular coagulation. Ariko iyo tuzi intravascular, it means nubwo yaba iri imbere muri heart, ventricles or atria, so all these will be called thrombosis. So what are the causes? Usually there is a damage, vascular damage, which causes that, but we shall see some three things which must be there in order to have a thrombus. So vascular damage with atheroma, toxins, there are blood changes. When there is stagnation of the blood or the blood flow is slowed down. So when it slows down, usually there are factors which come and cause injury to the endothelial cells. And when an endothelial cell is injured, automatically there can be hemorrhage. The blood can escape from the capillary and go outside where it should not happen. So in such cases, the body will trigger the clotting on that area so that the hemorrhage should not continue. So there are many types of thrombosis. So thrombosis is that situation whereby there is intravascular coagulation, but the clot itself, the medical term, it is thrombus or clot, but clot is just a secular term. In medical, you will use thrombus in French. So they can be white, red, or mixed. So the sites, there are sites which are known to have more of the thrombosis. On the artery parts, usually the thrombosis appears in the brain. You understand? With the brain, then there will be infarction, which is a stroke. It can be in the heart, and then it will cause a myocardial infarction. It can be in the limbs, therefore can cause gangrene. Aho uzabona ukuguru kose kwaboze kwabaye umukara. It can happen in the eyes, so umuntu azahita atakaza ijisho ye kubona. So the thrombosis also can appear into the veins, and usually this happens in the legs, as we shall see. And in the legs, akenshi bizamo kubera iki ni hari conditions zitari nyinshi zibitera. Icyambere ni uko umuntu aguma ahantu agumye ahantu hamwe umwanya munini. So kuguma ahantu hamwe umwanya munini bivuga ko amaraso adatembera neza, asa n'ahagaze. Cyane cyane muri veins. Kubera muzi yuko kugira ngo amaraso azamuke habaho muscle contraction, muscle zo mu maguru. When they contract, they push the blood to go upwards. Iyo amaraso azamutse, hari valves zihita zifunga ngo amaraso adasubira inyuma. Umuntu yakongera uko akora movement, none muscles zikongera zikazamura amaraso, and again valves zikafunga agasubira hasi, and so on. So you understand that now when somebody is immobile for hours, there is a risk that there will be a thrombus into the leg veins. And another condition, which is somehow similar to that, umuntu udakoresha amaguru cyane cyane ababazwe mu nda, cyane cyane muri pelvis, hano bagize fracture of the bone or pelvic bone, they are more prone to develop this, and so on. It can happen into capillaries, especially what we call disseminated intravascular coagulation. This is one of the most severe diseases or conditions. Ko umuntu wagize iki ngiki DIC, cyangwa gikanze yitwa CIVD, coagulation intravascular disseminée, umuntu wagize ntabwo bikunze ko yakira, kenshi barapfa. So it happens in a disease in conditions like septicemia. Septicemia means someone had infection, then the toxins from the injurious agent, usually bacteria, they spread inside the body through vascular channels, and then they cause systemic vasodilation. So akagira shock itewe na infection. So they get septicemia, septic shock. So that is in general thrombosis, but we'll come back on it after this short section on the normal hemostatic process. So you saw in the inflammation that when there is when there is injury to a tissue, there is a transient vasoconstriction. Ni ukuvuga ko habaho of the vessel ikagabanya karibu, ariko ibyo biba kanya gato, hahita hakurikiraho icyo bita vasodilation. So in vasoconstriction, we'll have endothelial cells which will contract basement membrane, arterial smooth muscle, which causes that contraction, of course. This is the normal side. The side which is now injured here, you see that we have the endothelial cells, they are lost here. So when endothelial cells are lost, bivuga ko amaraso aza in contact with the stroma here, which we call lamina propria. So uko umubiri wacu rero uteye nuko igihe cyose amaraso ahuye n'amaserateri endothelial cells, kiba ari ikibazo gikomeye, umubiri uhita ukora uko ushoboye ugahita ukora blood clot. So here there is a reflex vasoconstriction which takes just a few seconds. Then after that, there is the primary hemostasis. Nuko nko nabivuze, hahita haza platelets ziza gufunga aha hantu kugira ngo amaraso adakomeza kuva, guhitanga cyangwa guhura na extracellular na extravascular structures. So here we have platelet which will adhere here. So when the platelets aggregate, it is just a blood clot. This is how it forms. Ariko ntibirangirira akenshi, ntabwo ari platelets, hagenda hiyongeraho na red blood cells, hakaza white blood cells, hakaza collagen fiber, fibrin and so on. So iyo byose bijeho iba a large blood clot or a thrombus. But in normal conditions, or let's say physiological condition, there will be just a small blood clot, and after few maybe hours or days, this will be replaced by the So the platelet will be replaced by the endothelial cells. So that was the primary hemostasis. I think you have seen this in hematology, or you see it. So primary hemostasis, there is this platelet clot which comes there just transiently. After that, there will be, in addition to the platelets, we will have a fibrin, which means there are fibers, and there will be phospholipid and so on, which comes in. So there is a fat, there are fibrin, fibers, and of course the platelet. So in that case, you see that it is larger and it is more complex because it is composed of many things. So this is a secondary hemostasis. So then there is the antithrombotic counter-regulation. So meaning that there are things which will come to destroy the thrombus or that clot. This is in a physiological way. So ntabwo umubiri wakwemera ko iki kintu gikomeza gukura kubera ko umubiri uzi consequences zayo. So that's why hazamo ya system, you know, in a coagulation cascade, plasmin and so on, zizamo kugira ngo zishwanyure ibi bintu umubiri wongere ukore neza. So pro and anticoagulant activities of endothelial cells, they are explained here, antithrombin, thrombin, and so on, many factors here, so that we will not discuss. So platelet adhesion and the aggregation. So ntabwo platelet zipfa kuza gusa, ziba zifite von Willebrand factor. Hano niyo iba expressed kuri tissue hano, noneho on the basement membrane where the endothelial cells were situated, aho ziba zavuye zapfuye. So von Willebrand factor iba expressed, then ikaba ifite receptor yayo kuri platelet. Niyo mpamvu platelet iza ikahafata neza ikamatira. This is adhesion. It is not just a physical adhesion or aggregation. These are things are chemically mediated. So there are factors, there are mediators of these things, and so. And then fibrinogen will be between one platelet and another platelet. You see fibrinogen here, and the fibrinogen will have also its receptor here. So these receptors, some of them we have them in our clinical practice in histopathology. Attention to the pressure for other reasons not to specify these ones, because also they help us to know some types of cancers or how these cancers can be treated. So these are the things we use regularly in our hospitals, teaching hospitals. So this is a coagulation cascade, as you know, an extrinsic pathway and intrinsic pathway. So you have seen the details in normal hematology. But it comes here to just remind you where where the thrombus comes from. So if the thrombus here, there is a thrombin, which causes the thrombus to be formed, and then that thrombus will have to be destroyed through another system with plasmin. So fibrinolytic system where I have plasmin, not plasmin, and it is plasmin. So this is very helpful in destroying the blood clot. So what are the types of thrombus coming from that? This is basic science biochemistry. Now we come back to clinical aspects of it. So the thrombus can be white. I had said this. It can be red or mixed. So when it is white, it means it contains only platelet and fibrin. When it is red, it contains more of red blood cells, RBCs, so red blood cells. When it is mixed, it combines, of course, these platelet, fibrin, and red blood cells. So what are the sites which are most involved by white thrombus? It is heart valve and the artery. While for the mixed one, we have, again, heart chambers in the vein. So we have also fibrin thrombus, which is almost entirely composed of fibrin. You don't find the red blood cells and so on. So this is seen in glomerulus thrombi, higher in a thrombi. So thrombi is a plural of thrombus, also know Latin. So this is seen when there are problems into the kidney around the glomeruli. So I said there are three conditions which are known to be to initiate thrombosis. What are they? So they have been defined by someone called Virchow. Wow, this is history of pathology. Virchow's triad. There are three things which always work together to cause a thrombosis. There is endothelial injury. I think you understand because I have shown in the diagrams. There is abnormal blood flow, usually stagnation of the blood, or the flow is very slow, and there is hypercoagulability. So hypercoagulability means the blood of someone, he has a tendency to coagulate even without any other reason. So there are many causes, and I have sent you this presentation, and there is a link to practical images. Haraho murabona table muri iriya link. When you open it, there is a table of the causes, the possible causes of hypercoagulability. So there are many things. Many platelets. So the normal range ni 150 kwa 450 per microliter. So iyo birenzeho it is thrombocytosis. Iyo biri munsi cya 150 ni wa muntu uva amaraso buri kanya akantu gato kamushora agahita ava amaraso menshi kubera kadafite blood clotting system. So our bafite too much platelets, they have hypercoagulability status. Or there are people who someone has lost a lot of water, so sweating, yagize diarrhea, and so on, vomiting, too much vomiting. So amazi akasa namushiramo ku buryo mu blood vessels hasigaramo cells nyinshi kurusha water itself. So birumvikana ko viscosity or the concentration will be too high, and therefore bafite ibibazo nk'ibyo and so on. So there are many causes. So abnormal blood flow can be caused by vasodilation for any reason, inflammation or stagnation kubera occlusion which can be caused by a parasite or any other problem. So endothelial injury, anything which can injure there. So what are the possible outcomes of the thrombus? A thrombus can be absorbed. So it means iragenda igashonga yose igashira umubiri ukayimaraho. That is one. Ibi bishobora kubaho spontaneously, or it can be induced by treatment. So that's why iyo umurwayi bamenye ko afite iki kibazo bahita bamuha thrombolytic drugs. Nta nubwo ari ibintu bigoye. Aspirine ni ikinini kiboneka very easily anywhere. Ni umwe mu miti ishwanyaguza thrombus. But it will depend on the size of the thrombus. Niba ari gatoya kandi ari kamwe cyangwa ari dukeya, it is aspirin can do it. But when it is large or disseminated, then you need very stronger drugs. And another one is organization. So organization ni ukuvuga iki, niba hari iki blood clot inside the lumen, umubiri uzakora utwobo muri cya githrombus, amaraso anyuramo muri utwo twobo akomeza agende. Birumvikana ntabwo azagenda neza kuko ntabwo cyose kizaba kivuyemo, azaba ari jene ariko nibora hagira agenda. So that is organization cyangwa se canalization, hajemo utundi canals. Another possibility is calcification. It means there is a deposit of calcium salts until you see that it is calcified, it becomes like a bone tissue. So another fate is detachment, which is very, very dangerous. When there is a detachment, then agace gacitseho gahita kajyana n'amaraso yigende. So ni nkuko ushobora kubona hari umusozi ushobora gutenguka ukagwa mu mazi. Reka twite ko that is a thrombus. Hari igihe gishobora kugera igice kimwe cy'ubwo butaka bwari bwagiye mu ruzi bukajyana n'amazi. So consequences murazumva. If it is within an artery, muzi ko uko amaraso agenda muri atarigenda igabanya ubunini, ikageraho kaba gato arterial. So nuvuga ko ya tromba kagace ka thrombus kagiye kazagera hano gafunge amaraso ye gukomeza. This is what is called embolism, and it is the next part. So if it is in a vein, you know that a vein uko amaraso atembera vein igenda iba nini kugera ageze muri vena cava, then akagera ku mutima. So aho ngaho igice cyabayemo thrombus nta kibazo kinini kizagira, keretse ahandi thrombus yari iri hifunze burundu, ariko ntagira agace gacika amaraso agakomeza kagenda kajyana nayo. Ikibazo gikomeye n'iki kizaba, ka gace kazagenda karuhukire mu mutima iburyo, ventricle, right ventricle. Then from right ventricle, that blood with that detached fragment will be pumped towards the lungs. So iyo bigeze mu bihaha habamo icyo bita pulmonary embolism, which is very, very deadly, irica cyane. So I know people, I know a friend, she used to be in Butare, she was working there. So she got it and she was treated, she's fine, but it is very rare to see someone who is a survivor of such embolism. So this is what I was saying, embolism. So it means abnormal solid mass carried out within the blood. So it is different from thrombus. Thrombus is always coming from blood clot. And it can be ishwayo kuguma hamwe thrombus. Iyo itangiye kugenda igenda mu maraso ibaye embolism. So niho uzumva bavuga ngo uriya muntu afite thromboembolism, meaning he had thrombus, then detached, it went through artery and it became an embolism. So the condition itself will be summarized as thromboembolism. So it can be anything. We shall see the difference, the types of embolism or the sources. So it is very important to understand the source and the destination. The source and destination. Source ntabwo bivuga gusa icyayiteye, ahubwo navuga cyavukiye hehe. Kubera ko niba kivukiye muri venular part icyabiteye, bizaza muri right heart, then it will be pumped to the lungs. Lungs will suffer. If the source is within the arteries, then that solid mass will be carried out within the artery itself and cause occlusion somewhere. So the same if that problem is arising from the left heart. So left heart, a thrombus there, it will be carried out into the aorta, then nobody knows, either goes to the carotids, then the cerebral arteries, or goes to any other organ, to the heart itself, through the coronary arteries. So biterwa nuko bigenze then. So it means that two people, they can have both a thrombus inside the left heart, umwe akagira stroke, undi akagira myocardial infarction, undi bikamanuka muri femoral arteries, then ukugura akaba ariko kugira necrosis. So it is just there is a risk. Nobody can predefine this one will develop a myocardial infarction or gangrene of the limb or a stroke. So the types of embolism, we have a thromboembolism, which is mainly because of atherosclerosis. Atherosclerosis I have explained it before, but it will be the next chapter that we shall see. So there is a thrombus which is detached, and then it is carried through the blood inside the artery. It goes to occlude somewhere, to obstruct somewhere, and cause ischemia and infarction of a tissue or the whole organ. So this is a thrombus. It comes from blood itself. There is a fat embolism. So fat embolism bikunda kugaragara ku bantu bagize fracture of the long bones, nk'abantu bagize fracture of the femur. So because these long bones, they have much bone marrow, and the bone marrow is composed mainly of fat and some hematopoietic cells. So ahangaha rero bikunze kugaragara ko mu gihe umuntu agize fracture of the femur, ya fat yari irimo ishobora kwinjira muri vein. Muri veins, femoral veins, any of its branch. So if it enters there, then izakomeza yinjire muri femoral vein, the larger one, is muri inferior vena cava to the heart, then sent it to the lungs. Umuntu akazapfa kubera pulmonary embolism. So another type is the tumor. So cancers we shall see it when we reach this chapter, but cancers is characterized by the possibility to have some cells detached and go into the bloodstream or lymphatics and occlude somewhere. So that will be cancer embolism or tumor embolism. Gas, umwuka ushobora kwinjira mu maraso. So this is usually caused by intravenous therapeutic procedures. So bivuga iki ni igihe ufata kwa navangwa ni gufata vein. So ugafungura ugafata amaraso, that's okay, akasohoka. Ariko ikibazo kiba cyane cya gihe uhaye umuntu perfusion cyangwa ibyo twita serum cyangwa n'amaraso. So iyo serum ishizemo ntufunge wa mwuka wari uri muri rya cupa na uragenda. So that's why muzabona kwa buri gihe ikintu bitondera ni ukugira ngo serum idashira igakomeza ikagenda. Donc ntibayifunge. So niyo mpamvu ari umurwaza, ari umuntu wese abagomba kuba ari alert kugira ngo ijya gushiramo bayifunge umwuka utinjira. So iyo umwuka winjiye mu maraso uhinduka nk'ikintu kiri solid. So ni nkuko uramutse ufite agatibe ugashyiramo amazi akagenda, ukareka akagendamo air, irakomeza ikagenda. Ntabwo uvuga ngo air ntabwo ari vide, ntabwo ari vacuum. Air ni ikintu gifatika, niwo kukanga, ntabwo ari vacuum. So therefore ntabwo uzava ngo air neya ngo igiye nta kibazo ngo amaraso yandi nahagera compensatinga ase nayo naburizamo iyo gas, ntabwo bishoboka. So iyo gaze nayo irakomeza ikagenda ikaba yazafunga ahantu vessel, then umuntu akagira embolism. So there is a liquid cyane cyane ku babyeyi babyaye, amniotic fluid iriya umwana ababamo muri mu gihe abamutwite. So ira fluid mu gihe babyara hari abagira risk ira fluid kinjira muri vessels. Urumva mu kubyara buri gihe haba ari amaveso yacitse. So it is possible for that amniotic fluid to enter into a vein. So they say that it happens in 1/50,000 deliveries. Kwa babyeyi 50 babyaye umwe agira iyi risk. So I know somebody who was working at the hospital in Butare who she got this when she delivered. Yeah, I think in 2009. So she was working in the lab of the hospital. So she was pregnant. She delivered just normally, and then there was this condition. She died. So it is said that even in developed countries, more than 80% of these women will die. So this is in general embolism. This is a very fatal disease. When you diagnose someone with it, so you must work hard to rescue whenever possible. So the rapid onset of infection, it happened. So icyo bashaka kuvuga no iki nuko muri embolism there is a rapid onset of infection as compared to thrombosis. Because thrombosis iyo ibiri hamwe ifunga vessel gake gake kubera kwigenda ikura uko hazaho other platelets, other red blood cells, blood flow igenda igabanuka, tissue igasa naho ibimenyere ikaba injured slowly, ku buryo na signs and symptoms they will come slowly. But for the embolism kuko kazayenda gafunge rimwe kuri rimwe, amaraso ahagarara rimwe kuri rimwe, ntacyo twakwita nk'integuza y'azabaye kizaba cyabaye, then the symptoms will be of rapid onset as compared to the thrombosis. So what are the consequences, sequels or consequences of the block? So hari igihe bibaho umuntu akagira bita collateral circulation. So collateral circulation bivuga iki? Hari igihe hari uburyo umubiri w'umuntu uteye. So you have seen that in anatomy. Nuko hari ubwo ushobora gufunga uruhande rumwe, tuvuga nka carotid arteries. Imwe ishobora kwifunga, iy'ibumoso, iy'iburyo ifunguye, amaraso yayinyuzemo yagera hejuru agasaba akajya n'ahandi ibumoso hari habuze blood. So icyo nicyo bita collateral circulation. Ariko cyane cyane practically kigaragara he, muzamubona abana cyangwa abantu bakuru bafite cirrhosis. Cirrhosis ni fibrosis of the liver as we have seen in morning. So usually cirrhosis will cause the portal circulation to stop, if I can say so. So when it stops, kandi amaraso yahanyuraga avuye so arimo nutrients zizamutse ziva muri intestines and so on, aya maraso aba yanyuraga muri liver agakomeza akazayara muri inferior vena cava then mu mutima. So when there is too much fibrosis of the liver, which is cirrhosis, the portal circulation will no longer be possible. So umubiri ubigenza ute? Usubira muri embryogenesis. Umuntu asubira muri embryogenesis aho iyo umwijima utarakorwa hari bita vitelline sac, niyo iba akenshi ivamo ibitunga umwana, niba ko navuga embryo, ariko iyo vitelline sac muzi ko ibiri connected kuri umbilicus. So icyo gero bigenda bite? Amaraso yazamukaga muri portal tract and so on, ashaka inzira muri handi hari vitelline sac bikanyura muri umbilicus. So niho uzabona uwo muntu rero afite amaveso manini kunda manini ari kunyura mu maraso bireba. Kubera iki? Aya maraso agomba kunyura handi imbere asigaye anyura kuri abdominal wall, kubera ko niho yabonye inzira. So that is also called a collateral saturation. So another consequence is ischemia. You understand? Ischemia means there is no longer blood supply to an organ. So ischemia, it is reversible injury, meaning that it is a transient. But when it is there for minutes, then there will be infarction. Infarction or death of the cells is irreversible. So if it is within the limbs, it will be gangrene. Intestines, usually it is called gangrene. But when it is in the heart, we call myocardial infarction. If it is in the brain, it will be a stroke and so on. Another possible consequence is hemorrhage, especially if after the block, the vessel ruptures and there will be hemorrhage. So the most common sites of blood vessel block are these ones. So first, let's start from the head. So ikibazo akenshi kiba muri carotid arteries. So if there is a carotid artery, ni ukuvuga ko amaraso nubwo hari collateral circulation, ariko ubwonko bukeneye amaraso ahagije atagomba kugabanuka. So iyo agabanutse, then hari igice kibura amaraso, icyo gice rero kigira infarction. So clinically ni wazaba ko umuntu yagize stroke, ariko stroke irimo amoko abiri, hari iterwa na infarction kandi iterwa na hemorrhage. Then if there is a block inside the carotid, not the carotid, inside the coronary arteries, the consequences will be the myocardial infarction. The part which should be supplied by that coronary artery, it will die. So sometimes the other consequences are the aneurysm, aortic aneurysm. Aortic aneurysm ni kwa kundi nabivuze kare, vesi irabyimba cyane, nkanga yabyimbye ku ruhande rumwe kubera iki, the wall is weak. The wall can be weakened by many things, including atherosclerosis, as we shall see next time. So then, when there is an aneurysm and there is a rupture, murumvikana amaraso yose yamanuka muri aorta ntabwo azakomeza muri vessels, azahita ajya muri abdominal cavity, then umuntu ahita apfa. So it is one of the causes of sudden death. So the block can be within, for example, femoral artery or iliac artery and so on. Aho niho uzasanga umuntu yagize gangrene, ugasanga ikirenge cyose cyabaye umukara completely, atacyumva gukoraho ntiyumve ko umukozeho, tera agashinge cyangwa ikintu ntiyumve. So because it is completely dead. So this is gangrene, kiba kisa n'umukara. So iyo ibayeho nta kindi ukora, kuko udakoze amputation irakomeza ikazamuka. So niyo mpamvu kwa muganga utanguranwa ugahita ukora amputation hakiri kare ngo bidakomeza kuzamuka. Kandi uretse no kuzamuka hari ubwo biba infected, then hazamo bacteria and so on, none wa muntu akazagira na severe infection which can cause septicemia. Okay, so coming to the heart, coronary atherosclerosis. So there is a typing error here, atherosclerosis. So you see, this is the heart pumping. These are a right coronary artery. Here we have a left, the main coronary artery and the circumferential. So remember the anatomy. So then, for example, here I think it is this one. The right coronary artery here is blocked. So if it is blocked, the part which was irrigated by this coronary artery will undergo necrosis. Ischemia first and then necrosis which is infection. Here it is specifically infection. The block can also appear here at the left main coronary artery and so on. So ahangana umuntu wagize myocardial infarction, so the few who survive, but survive for a few hours or days. Otherwise, usually these are people who die automatically. Abantu benshi bakunda gupfira mu mahoteli usanga akenshi hari iki kibazo bagize. So akenshi usanga n'umuntu wakoze urugendo rero wenda n'indege, gari ya moshi n'ibindi, of course urwo rugendo rutuma aba immobile, akaba habaho blood clotting mu maguru, and then yaza gukora muvoma ya blood clot ikazamuka ikazagera mu mutima, then igatera myocardial infarction. So bikunda kubaho nubwo akenshi bakora autopsy bagasanga ni coronary artery, ariko sinzi n'impamvu akenshi abagiye mu mahoteli aribo biko. So I don't know. I know many cases of such kind, but ntabwo byumvikana ko wenda akenshi bagendanye n'abandi bo batahashye mu ngo zabo ntibagire icyo kibazo, ariko bagiye muri hoteli kanye cyo. So nka mystery, I don't know. So these were diagrams, ni bishushanyo. So in a true picture nukora autopsy uzasanga blood clot hano harimo akantu k'umukara hanga nakangako bo katumye uyu muntu. So no yango ni ibintu biba ari binini cyane. So azasanga umuntu. So I remember when I was in training, so there was someone who traveled yari yavuye muri Canada ajya muri hoteli gitondo basanga yapfuye. So autopsy dusanga it is just a small just a clot like this causing the death of someone. So ari umuntu munini cyane. So n'utuntu duto uzasanga na kenshi abantu bapfuye kubera bagize cerebral edema, uzasanga n'akantu gato cyane tugira gyrus of the brain kagize herniation gato cyane, usanga niko kamwe. Ntabwo buri gihe ari ibintu binini mu bigaragara biba byabishe utuntu duto nk'utu. Okay, so this is a case of coronary thrombosis with infarction. So this is a lung. A lung is in vessels. Then byensiri bakoze autopsy cyangwa se ni bakuyemo lung yari necrotic. Then ufungura ugasanga iki ni blood clot cyaje gifunga cyaje gifunga atari aho yari igiye kugira ama branches. So this is a pulmonary embolism. So hari aho bashobora nko kuyona hakiri kare iyo ari kinini nk'iki, navuga ngo bimeze nk'amahirwe aho ari ibitaro bahita babibona vuba bagahita bakora nka bronchoscopy, iki kintu bakakivanishamo bronchoscopy kuko ari kinini, ariko hari utuntu duto twagiye mu tuveso duto, of course it is not possible to do. So aorta dissecting aneurysm. So aneurysm muri make ni of a dilation of just a focal dilation of a blood vessel containing blood. Hari icyo bita dissecting. Dissecting iyo iragenda igasaturamo imbere muri wo mo hagati muri tunica media ikamemamo indi pocket. So this is what is called dissecting aneurysm. So this is a brain hemorrhage. You see these blackish things here. These are blood clots. So this is subarachnoid hemorrhage. So subarachnoid hemorrhage murumva kuri hagati ya arachnoid ndetse na brain itself. So when it is the extradural or subdural, it is another story. So when that is uzabibona nyuma muri surgery and so on. Ariko umuntu wagize extradural no kuvuga outside the dura mater, just this means between the bone and the dura mater itself. Akenshi abangaba uzabibona clinically umuntu wenda uzabagize accident cyangwa traumatism ku mutwe, mu kanya gato azabakanye kujya neurological science n'ubukoze x-ray uzahitona ko ari hematoma. Uwo nta zindi discussion, ugomba gufungura umutwe ugakuramo hematoma ko otherwise ubwonko ntabwo bufite ahantu bwinyagamburira, uzagira herniation towards the spinal cord. Herniation ijya kuba umuntu apfuye. So in emergency, so clinically rero usanga ari masse nini ikura vuba ya hemorrhage. But for the subdural hematoma, which is below the dura, between the dura and maybe arachnoid and so on. Yo is a slowly. And the pathophysiology behind that is that the subdural hematoma is usually caused by a rupture of a vein, while the extradural is caused by a rupture in an artery. So you understand when there's a rupture in the artery, the blood which is coming is too much, so as compared to the one coming through the vein. Niyo mpamvu muri extradural signs and symptoms ziza vuba vuba, naho yari subdural sinya n'ubwo ziza ku munsi wa kabiri cyangwa wa gatatu. So another condition is varices. Varices, I have talked how the blood flow is done through veins. Nuko iyo habayeho amaraso azamutse kubera either muscular contraction, kubera movement umuntu ari gukora, iyo amaraso azamutse there are valves inside the veins zihita ziyafata ngo adasubira inyuma. Amaraso akongera kuzamuka nanone valve zikongera zikaya. So valve yifungura ubujya hejuru, ntabwo yifungura ubujya hasi. So iyo habaye ikibazo valve ikaba prolapsing cyangwa se defective, nukuba ntishobore gufata amaraso ahubwo ikongera ikayarekura agasubira hasi. Ibyo bituma amaraso yenda akipfundika ahantu, nibyo bita varices. So it is just simple like that. I think I explained the pathophysiology of that. So varices nuko zivuka, then but there can be some underlying conditions. Nano hari igihe hariho ikindi kibazo cyatumye izo valve zidakora akazi kazo. So kuba ari chemicals zangije, ariko ikindi kiba niba hari ikintu kiri gutuma n'ubundi amaraso kuyanga azamuke bigorana. Tuba umuntu aratwite, niba twite hari uburyo inda ikora compression on the vena cava, inferior vena cava. Niba hari compression amaraso kuzamuka bikayagora, ibizagira effect kumanuka kwera kuri za venules. Therefore icyo gihe nubwo valves zaba zishoboye akazi kazo, ariko bwa buremere bwa grosses buzatuma zisa n'izineshwa amaraso ajya asubira hasi. So muzabibona kwa muganga umudamu agiye kubyara afite varices ku maguru, around the anus, around the genitals, akimara kubyara mu minota 5 uzasanga za varices zose zagiye. Kubera iki? Ya grosses yatumaga amaraso atazamuka neza yavuyeho, na kubera ko yarase inzu yifite valves nzima zizahita zitangira noneho kwerekana ko ari nzima, then valve azajya guhaguruka aho yabyariye, varices zagiye. So izo ni zateye na grosses, ari n'ifauterwa n'ibindi bibazo bishobora. So but one of the complications of the varices, it is venous ulcer. Hari n'abayita ngira ngo mu Gifaransa biho bayita ko ari ulcer muri varices. So usually it will be a wound which is not healed. Izaba ari igisebe, harabavura abakoza bakamuha antibiotics, ntugikire akenshi nicyo kibiranga. Any question so far? Okay, so if no question, then we can look at the infarct and then have a break. So infarct, we have one infection, it is the death of tissues. So is the localized area of ischemic necrosis in a tissue or organ produced by occlusion of either its arterial supply or its venous drainage. Either of arterial supply is cut or the venous drainage is blocked. So this is a process whereby the infarct is developed, is known as infection. So the process whereby the infarct is developed is called infarction. So we have two kinds of infarct. There is white infarct. Akenshi bavuga ko ari yatewe na anemia, tuvuga ndi yatewe na ischemia, kubera ko blood artery yabaye blocked wenda na thrombus and so on. So icyo gihe uzasanga abantu heruruka ikunda kuba kuri firm tissues zikomeye wenda nk'iy'umwijima ya umutima myocardium akenshi hari necrotic uzasanga heruruka kurusha ahari aho amaraso agera. So here, but here we have an example of the spleen. This is a spleen. So it is associated with arterial occlusions. And the red infarct or hemorrhagic infarct, it is caused by venous occlusions. So you understand that there is a striking difference. The red is caused by the venous occlusion, while the white is caused by arterial occlusion. This happens in loose tissues such as this is the lung, with dual saturation. Dual saturation ni ukubera iki? Ibihaha bifite two saturation. Hari circulation ya yindi izana amaraso aje gusukurwa, aje guhabwa oxygen, hakaba na saturation isanzwe yohereza amaraso atunga ibihaha mu buryo busanzwe. So there are two things. So no kuvuga ko ahangaha akenshi infection muri ahangaha izaterwa na occlusion in artery of one of these two systems. Kwako another system is still working, if you can say so, there will be hemorrhage kuko hazashwanyuka kubera infection, but because there is one system which is still sending blood there, then there will be hemorrhage when the blood reaches somewhere and it finds the blood vessel was necrotized. So, and the gangrene, as we said, this is a gangrene of 2. Ushobora guterwa n'ibintu byinshi, ntabwo ari gusa ya blood clot yaje muri vessels hano. Nibuka ko when we are doing at Doc 2, hari abantu babiri, umwe yari yaranatwishe muri kaminuza, barumwe n'abagore babo. So undi yari umuturage, but umwe bombi bageze barumwe n'abagore babo ari ku rutoki nkuru exactly. So rugira gangrene nako baravuga mu macandwe y'umuntu ahashobora kuzamo ubumara burusha n'ubw'inyamaswa. So barahavuraga bikanga, hanyuma bagakora amputation. So nibuka ko mwarimu we bagakase kugera nk'aha ngaha, gatoki kose gashiraho, but for the other one byabaye ngombwa ko baca n'ikiganza biranga, baca forearm biranga, bakomeza bakora n'ukuboko kose. So aho namuherukiye ntabwo byari bigeze. So bizana gangrene. So ntabwo gangrene rero bigiterwa gusa na occlusion by a clot or thrombus. It can be caused by many other things. So we can have a 10 minutes break and come back for the next part, which is mainly shock, edema. Yeah, ngira ngo nibyo sigaye cyane we must discuss. Thank you. But if there is any question, you can ask it before we break. Okay, no question. So we have we come back at 40 minutes past 3 p.m. Okay, so let's proceed. Someone asked if the venous congestion is the one causing the varices and the ulcers, but not really. There are some relationship between themselves, because a congestion means venular congestion. There is a decreased outflow. There is a decreased outflow of the at the venular end. So ibyo bituma niba ari kuri venular end, therefore ntaho yabihuriye na varices, kuko varices ni kuri vene nini hejuru ugana ku mutima. So congestion na hyperemia bivugwa kuri around the capillaries. So hyperemia at the arterial end, and then the congestion at the venular end. So gusa iyi outflow blockage ishobora no kuba hejuru kure cyane ikavukamo varices, and at the end hakazamo na congestion. Bivuga biturutse wenda kuri femoral artery, hari occlusion, then hagahita hakurikiraho varices ku maguru ahagaragara ku maveso manini kuri larger veins, then congestion it will be at the venules, yes, microscopic vessels. So ntabwo twavuga ko bijyana buri gihe, bishobora guhurirana ariko ni ibintu bitandukanye. So bivuga ko umuntu ashobora kugira hyperemia ariko adafite congestion, ni igishoboka cyane. Sorry, ashobora kugira congestion ariko adafite varices. Ni ikintu gishoboka kubera occlusion yabereye at microscopic part, aho za valve ziba n'ubundi zidahari. So the things we are learning here, this is a general pathology, of course. We are learning principles, and these principles will be applied to specific organs now. When you go to systemic pathology, or when you go to surgery, internal medicine, and so on, you will apply these principles. If we say how a tumor develops or how ischemia develops here in general pathology, now when you are dealing with cardiovascular diseases, it is where you will explore more of these things. Unfortunately, some of these things you will explore them when you are in clinics. In clinics, kuko uzajya uhura n'ibintu utasomye utigeze ubona mu bitabo. So you must now understand them in terms of basic sciences. In terms of basic sciences, and as I said, these things they will help you to sort out some problems. Hari uburwayi bwabwo, hari abantu ba accusations and so on. I remember when I was in training, haje umuntu afite umwana we, okay, twamubonye yapfuye, none baratubwira bati umugabo aravuga ati yavuga mu ndimi zabo ntashoboraga kumva. Umwarimu kandi kumwe ati ari kuvuga ko umwana we yari ku ishuri ari gukina n'abandi bana, umwana w'umuturanyi aramusunika aragwa agusha umutwe abaho. Hashize ibyumweru 2 atangira kugira fevers, bamujyana kuri hospital, iramutransfer kuri referral hospital imurefera kuri national hospital twari turi then. Umwana akihagera amasaha make barapfuye. So akavuga ati rero ujye umwana wanjye yishwe nako kana kandi bagomba kubyishyura. So we do that autopsy at opening the head. Twaze tuga kuri pass. So meaning that this child had just meningitis. Ni ibintu byahuriranye kubera ko yigeze kugwa, urumva yashize n'igihe, nyuma agira umuriro. Icyo cyari very important, kuko navuga ngo yaguye hasi ntashije ibyumweru 2 ngo agire umuriro uvuge ngo hari ahantu bihuriye. Umuriro means infection. If it was just inflammation, it could happen that day because it could be acute to the traumatism. Then nubwo ethically bisa n'ibitemewe, so umwami waravuze ati reka uyu muntu tumwereke atagenda no gutera amano ugasanga bagiye kwihorera cyangwa gukora ibindi. so aramwereka ati dore umwana afite PAS. So kuba yifite bivuga ko infection yagize ahubwo yatinze kuvurwa. Uwo muryango wundi rero ntimurebe nabi ntaho bihuriye. So bivuga ko ubukemuye ikibazo utagiye no muri histology, utagiye gukora microbiology, because if there is a PAS, it is not caused by traumatism, because there was no bone fracture which had happened, there was no hemorrhage, just the PAS, meaning there is the acute bacterial infection. There has been bacterial infection. So when I was working in the district hospital also here, there are many cases of forensic nature. And when I was working at Sashika, there are some postgraduate students, they were rotating at the police hospital, then at the forensic lab. Then babazana umuntu wapfuye ngo yari yanyoye cyane aragenda mu mihanda niba ari bice bya Kagugu, then bamusanga ku muhanda yapfuye, bati yishwe rero nta bindi. So bajya bamukora autopsy Kacyiru, bagifunga babona a very big tumor in the pancreas. They took biopsy, then we examined, it was just a cancer. But bamukotos basanze yavuye cyane. So hypothesis ni uko kubera iyo cancer yagize rupture of some vessels, and then arableedinga ahita apfira aho ngaho. Birumvikana ko ngo bari bafashe abantu bari barimo basangira bati kwa mwe muri gusangira nubwo bigaya ko yapfuye yavuye hano ariko nimwe mufite amakuru ya nyuma mugomba kuzabibaza. So it was reported it was just a natural death. So icyo gihe hari abantu bukijije and so on. And when I was working in this hospital, I wanted to say that I remember so haje bazanye umugore wari utwite yapfuye n'umugabo we yapfuye, ariko bashyize umugozi, hari umugabo afite umugozi mu ijosi. So baravuga bati nyine murumva uyu muntu buriya yishe umugore wari utwite amaze kumwica nawe ariyahura. So in such cases, you don't have to be misled by the opinions of the population y'abaturage cyangwa y'abantu nyamwinshi ngo bakwa influence. So we went on examining. So nubwo umuntu yaba afite umugozi mu ijosi bamuhambiriye, umuntu wiyahuye hari uburyo bizwi muri science umugozi ubuteye wamwishe. So dusanga umugozi ntabwo ariko byari bimeze, ahantu ugomba kuba wanyuze niba ari ukuyahura siho wanyuze. So we reported no, we think this is not true. We find that uyu mugozi washyizweho umuntu yapfuye ntabwo umugozi ari wamwishe because of this and this. So that time RIB was not there, the police yabikoraga, so bakurikirana abantu. So at the end bemeye ko aribo babishe bose hanyuma bahimba ibyo ngibyo. So because just of that small thing, kumenya ngo umugozi wica umuntu wiyahuje umugozi uzamuka inyuma y'ugutwi gatoya ukaba uberamye, ntabwo utambika ku ijosi. Niyo umugozi utambitse ku ijosi ni uko ari umuntu wahambiriyeho nyuma, ntabwo ari uwamwe. Icyo cyonyine cyatumye ukuri kumenyekana, agomba guhanwa barahana. So just to explain that these things are applicable in the daily activities as a medical doctor. So as a medical doctor, usually ntabwo muzagira hari rotations in forensic areas, ariko nugera muri hospital, any case medical doctor is required. Nta nubwo ari ukubisabwa, ategetswe gutanga igisubizo ku bintu nk'ibyo. Niyo umuntu yapfuye mujyana mu binyamakuru bavuga ngo basanze umurambo ahantu, bahise bawujyana ku bitaro bya Nyagatare cyangwa se ibitaro bya Gihundwe and so on. Aho ngaho nta mupathologist wari, nta weza forensic wari. It is a medical doctor, he is required, ategetswe kuyikora these things, ni afatwa nka expert. So niwe bandikira ngo tugusabye gutanga expertise yawe hanga. So usually because you will not have much exposure to forensics, you have to apply what you have learned in other sciences, basic sciences, pathology and clinical sciences, in order to sort out such cases. So shock is a state of circulatory collapse. So umuntu ari muri shock ni ukuvuga abafite koma birumvikana ko niba amaraso ari kugenda ubwonko n'izindi organ ntabwo zazibona amaraso ahagije. So shock ikenshi ijyana na koma, ariko ikibazo gikomeye nka si koma ni shock. So there is ineffective tissue perfusion which leads to widespread hypoxic tissue injury and death when not effectively treated. So there are major types of shock. Hari hypovolemic, wenda umuntu yatakaje amaraso yavuye, yagize fracture, yagize accident, ava amaraso menshi cyane, cyangwa se ugiye kubaga umuntu usanze afite kanseri, kandi kanseri ifite veso nyinshi cyane, irapfa ku buryo bukomeye, unanirwa gukora hemostasis, then uwo muntu ahita ajya muri shock. So kugira ngo atajya muri shock, mpamvu usanga bari kubaga bavuga bati iyo baceka ko ari umuntu uzatakaza amaraso menshi, usaba amaraso kare, bakamukorera blood grouping, bakamukodaringa amaraso, bati mumuzane wenda amasashe 3-4 abe ahari. So ikindi ashobora kuba yatewe na severe burn. When someone is having a severe burn, he loses a lot of fluid through the skin, of course. Or after severe diarrhea and so on, he loses a lot of fluids and many other causes. Hari naho bavuga ko na sweating, umuntu ashobora gusweatinga cyane kugera ubwo aguye muri shock. So iyo yita hypovolemic. Cardiogenic, it is when there is ineffective cardiac output due to the pump failure. So amaraso arahagije, blood vessels nta kibazo afite, ariko umutima ubwawo ntufite imbaraga zo kohereza. So blood pressure ibiri hasi cyane. Ngira ngo ni nacyo kimenyetso cya mbere cya shock, nuko blood pressure is very low. Rimwe na rimwe nta nubwo uyibona, ubona 3/0, cyangwa ntugire icyo ubona. Wafata umutsi muzi uburyo wafata pass kuri atari zinyura hano ku kuboko, umutima ntushobore kuwumva. Wajya ku mutima ugashyiraho stethoscope kumva kari gutera gake cyane, ukavuga uti nubwo kari gutera gake ariko karacyatera, reka uyu muntu ngerageze uburyo namusova. So the septic shock, it is caused by toxic effect of systemic infection leading to widespread of vasodilation, pooling of blood, and impaired cardiac function. Anaphylactic shock, it is hypersensitivity, niterwa na allergy, a very severe allergy. Cyane cyane biba nko ku muntu wigeze agira allergy ku kintu akongera akagihawe. So umuntu yagize allergy kuri penicillins, ko dufite abantu benshi bagira allergy kuri iriya miti ya penicillins. N'amoko menshi, amoxicilline, chlorhexidine, ampicilline, many of them, they are very many. So ukaba utabizi ukongera ukamuha undi. Bwa mbere reaction ya mbere iba itari grave, ariko ya kabiri is very severe, agahita agwa muri anaphylactic shock. So neurogenic, there is a vascular loss of vascular tone and peripheral pooling of the blood. So ni nka vasodilation gusa yaje hariya muri itewe nuko vessels they are too much vasodilated. So muri rusange izi shock zose muri clinical settings muzazibona, ariko so what I would advise you whenever you have a case of shock, kuko icyambere cyaza muri koma ntumenya ngo ni iki cyanamubaye. As a medical doctor, please, you will have to treat every case of shock as a septic shock. Why? Kuko septic shock combining ibintu byose turi kubona hano. Umuntu ufite septic shock aba afite na sinye yuko ari cardiogenic, ari hypovolemic, ari anaphylactic, ari neurogenic. So therefore you wakira umuntu uri muri shock, ntabwo uvuga ngo ndabanza nshake iyi shock yatewe iki na anaphylactic ni septic. So icyo gihe ujya kuyishaka hazaba yapfuye. So the procedure we do is always to take that case as if it is a septic shock. Septic shock ro uzayivura gute? Icyambere you give very strong antibiotics. Kuko ntabwo uzi niba ari ko septic shock, ntabwo uzi bacteria biteye. So icyo gihe umuha imiti coveringa gram negative bacteria, akenshi ushyiramo za fragile cyangwa metronidazole, ugashyiramo strong antibiotics zindi nk'izi za penicillins and so on. Ikibazo ni igihe yaba yagize shock iturutse kuri penicillin. So ibyo ukabimuha ukamuha na okay fragile ibizareba gram negative bacteria ariko kanareba na parasitic niba ari parasitic. Ikindi witaho ni malaria muri area yacu ashaka itewe na malaria, so quinine will be there or any other intravenous given drugs. Birumvikana byose bizaba binyura mu mitsi. Kumufatira umutsi ntibabyoroshye ko amaraso abatagenda asa n'abatagenda gusa muragerageza mukayifata. So is only on the part of infection. Ikindi umuha niki umuha imiti yahagurutsa umutima adrenaline ikawuha imbaraga, because here we see that there is a failure of the pump. So you make sure you give we give drugs to reinforce the heart pump. So adrenaline ni ikunda gutanga. So you consider that maybe he has a hypovolemia, nukuba yenda atakaje amazi hamwe amaraso. So icyo gihe tumuha serum ugahita umuha n'amaraso. So ashobora no kuba yafite anaphylactic shock, allergy which is very intense. So umuha imiti irwanya allergy antihistaminic. So you must combine these things. Then iyo ubiri kubimuha akenshi agenda agarura ubuyanja gake. Then icyo gihe ariko kameme ntabwo ubundi umuha antibiotics tabanje kumufata amaraso. Mu gihe bari kumufata imitsi yo gushyira amaserumu n'amaraso bahita bafata amaraso bakaba bayijyanye kwapima malaria, then infections and so on, ku buryo ni naho bafata yo gukora groupage sange blood grouping kugira ngo babone ayo bamuha transfusion. Then ibisubizo bitangira kuza akenshi nawe yatangiye kugarura ubuyanja. So hagati aho ko ari no muri komani ki ashobora kuba anafite hypoglycemia, kandi hypoglycemia ni ikintu cyica vuba kurusha hyperglycemia, cyo gihe muhana glucose. So I still think this because I have done this, and most of these cases I have rescued them. When I was working in this hospital, we had a problem with hari abantu batkoraga transfer abarwayi bava kure ariko abarwayi batabafa sinzi nawe kutabafata neza, ugasanga umuntu abo niba ndabona abadamu babyaye placenta zikabahera maze kanga kuza inda ya nyuma ntizi. So ugasanga bene uwo muntu arava cyane iyo placenta itahise ivamo, noneho akaza yakatujya bari muri shock kuri stage yanyu. Nibuka ko hari uwapfuye ageze ku marembo y'ibitaro ariko uwashoboye gukandagira ku gitanda wese muri abo ngabo, kandi byagiye bimbaho kenshi ndi kwiza, so wese yashoboye gukira. So iyo yazaga ameze gutyo shock, wenda byo byahitaga bigaragara ko ari hypovolemic kubera hemorrhage, kubera bahitaga bibona placenta ikinagana hariya korido yayo ikinagana. So hari n'abaforomo baga bamuzanye bakabikubwira. So niba icyo nakoze bwa mbere nkibona, I didn't know what to do. So abanasezi nibo banyigishije icyo gukora. So nari imizi mu bitabo baravuga ngo ni umuntu placenta muhezemo byatse dusa cesarean section, nubwo umwana yari yavutse uyikuremo. Ariko ukareba nk'umugabo bati ndamubaga gute ari muri shock, ni gute wabaga umuntu ari muri shock? Icyo ntibishoboka, ni ukumwe. So barambwira ati ambaraga ujyana ukuboko ugere muri terisi uyimanura, nta yindi shuri ntari. Narabikoze mbona ivuye bwa mbere. So ubwo nari bimenyereye, nta ibintu ntari narize mu ishuri, but nurses no mpamvu utagomba gusuzugura abantu ngo naba nurses ngo urabasumba, ni abatravel cyangwa attendants ngo no kwa muganga, ni collaboration, umubare wese arakwigisha. So akenshi ariko ntabwo kaza twikora icyambere kwari kumufata vein, kwafaya vein enye nibura imwe gahita ijyamo serum zirukanka mu munota umwe kabiranye gashyiraho indi nkangure ko umutima wateruka wumva. So akenshi kazamukaga ari gake, ugahita umuha indi izamura amaproteine bita hemacell, iyo ntishobora kwihuta hamanuka gatonya, ariko iyo hagiye akambira ukabona karakunze umenya ko umurwayi biri bukunde. Iyo kagiye hagenda udutonye 10 blood pressure atangiye kuza. So ubwo mu yindi vein hamwe washyizemo range lactate, indi washyizemo hemacell, indi ushyizemo glucose, kwari muri shock ari muri koma ashobora kuba anahite nuko nta ari inzara glycemic yagiye hasi, then icyo gihe ukabutegereje amaraso ajya kuza, blood pressure atangiye kuza gakeya, then icyo gihe abatangiye kuba stable, ukamutera ikinya gatoya ketamine, ukamukora placenta, mu minota 30 umuntu aba atangiye kukuganiriza yishimye. So but this is hypovolemic shock. So for septic shock it takes time for them to recover. Ariko ni itegeko, whenever you have a patient with a shock and they don't know the cause, treat it as a septic shock. So you combine perfusion, transfusion, antibiotics, and the drugs which will potentiate the heart pump. So the shock, it will be characterized by rapid weak pulse, tachycardia. You know this sign. Tachycardia means touchy. It means ibintu byinshi. Cardia, then it is cardiac rhythm. The opposite is brachycardia. Low blood pressure or hypotension, rimwe na rimwe ntunayibona na gato. Cool clammy skin, so and reduce the urine. Yeah, this is a sign. Nani bagiye kukivuga. Ikindi nuko kuvura umuntu ufite shock, arangwa nuko there is no urine. Kubera ko urine ziza ari uko impyiko zabonye enough blood to filtrate. When there is no enough blood, no urine will come. So ikintu kizakorera ko umuntu avuye muri shock, nubwo yakuganiriza agatangira kukubwira, kugushimira, muganga uranzuye bwiza gute, igihe cyose urine itaraza, don't say uko umuntu yakize akiri muri shock. Iyo zije, then you celebrate that the person has been rescued. Hari abaganga bamwe bava mu bihugu bikomeye by'uburengerazuba bigeze bazi akavuga ngo akavura umuntu akavuga ati jewe nzamenya ko avuye muri shock ari uko yagize pulmonary edema. This is a dangerous, for pulmonary edema irica. Nuko amazi yuzura ibihaha ntibishobore kwinjiza umwuka. Bakavuga ngo nicyo kibinyereka. Ugasanga na abantu bakora hari ibintu, so I don't know, batazi cyangwa abaga benshi aribo bagitangira kuvura batarigeze bakora practice. Ariko as you must know that to ensure that someone has recovered from a shock, there must be urine. So there are clinical stages of shock. There is the initial non-progressive phase. Abafite zira signs zisanzwe ariko adafite ibibazo bikomeye. So ari muri shock byensire, blood pressure is very low cyangwa uyibona, but when there is a progressive stage, now usanga harimo worsening, saturated in the metabolic imbalances and acidosis. Wapima blood pH of the blood ugasanga yagiye muri acid. This is very dangerous. Umenya ko ari muri progressive stage. Then irreversible stage ni nko kuvuga ko uko byagenda kose umuntu atari bukire, naho usanga organe nyinshi zafailinze, kidney completely damaged, liver completely damaged, brain completely damaged. So this is not a person who can be rescued. So there are special features of septic shock. So muzabyiga endotoxins nizo zibitera cyane. So you will read this. Ariko ikinyenza kumenya nuko ziba zaturutse kuri gram negative bacteria, mpamvu navuze cyane kuri amuti wa metronidazole wo twakoreshaga cyane ushoboye gram negative bacteria. Gram positive bacteria ugashyiramo indi miti ikomeye twakoreshaga ceftaxime, ceftriaxone, icyo gihe ubu harimo za imipenem and so on. So twashyiraho n'imiti ya malaria kuko ntibaguze cyabiteye. So icyo nshaka kuvuga hano nuko infection, you know that it is usually characterized by high fever. Muri septic shock sometimes is the opposite. Abafite very low temperature 35 n'igice. The norm is 36.5 up to 37. Ariko asanga yagiye muri hypothermia. Aho rero ntabwo ari sinya yuko atari infection, ahubwo it may be a sign that there is a very severe infection. So that is also a clue you must keep in your mind. So this diagram is explaining the pathomechanisms, possible pathomechanism to have a shock. So there are many things. So there are endotoxin, lipid A, peptidoglycans, from the membrane and cell damage. This can be from endothelial, it will induce activation in endothelial cells, platelets, macrophages, neutrophils, and so on. Ngira ngo ikigarukamo hano twavuze ko disseminated intravascular coagulation. So ikibundi giterwa n'iki ni uko uyu muntu nubwo afite coagulation udukoroti twinshi mu maraso hirya no hino, ariko iyo tubaye wowe ushobora kuvuga ngo ubwo ntabwo ashobora kubleedinga, but it is the opposite. So bivugwa ko icyo wafata nka take home message kuri aba bantu nuko aba yagize blood clots twinshi hirya no hino ku buryo the factors for blood clot have been exhausted, na kamwe asigaranye muri reserve. As a consequence, this person can bleed very easily without even a tremendous, a large, severe trauma. He can bleed very easily. So nicyo kiranga abantu bafite CVD cyangwa DIC. So ufite umurwayi rero ntabwo bava ngo buriya afite coagulation cyane ngo ndamuha fibrinolytic cyangwa thrombolytic drugs. No, ahubwo ugomba kumuha ibituma nibura afuma, ibituma habaho more coagulation, because the risk of this person to die is by hemorrhage rather than by clots. So effects of septic shock bikigaragara. So in low quantities you can have local inflammation. In moderate quantities systemic effects, and in high quantity you go ajya septic shock. So you read this diagram, and it is in that book of Lobin's I mentioned when we started. So here we have the pathology of severe shock. So severe shock, kubera ko ubwonko bumaze umwanya butabona amaraso bushobora kugira brain death. Also fever bayerekanya no mutwe kubera kimuzi ko it is regulated by hypothalamus. That is the reason. So adult respiratory distress syndrome, mu bihaha bye akamera nk'abantu babaga bafite severe COVID-19 disease. Central lobular hemorrhagic necrosis of the liver, acute tubular necrosis of kidney, moreover impamvu agira renal failure, impamvu agira liver failure, impamvu agira myocardial infarction or necrosis, and so on. So most of his organs will be just dead before the death itself happens. So the next part is the fluid disorders after shock. So I know we will learn this more in the metabolic diseases cyangwa se mwarabibonye muri biochemistry about shock, but it is just to tell you what you must take, or how you must go for management when you have such cases. So the fluid disorders, they can be overhydration, dehydration, and edema. So overhydration kuba umuntu yahawe amazi afite amazi menshi. So birumvikana amazi akenshi ntabwo arayo aba yanyoye, ahubwo n'amazi ushobora kumuha muri perfusion. Bya bindi navugaga abantu bavuga ngo nge nzamenya ko umuntu yabonye amazi ahagije noneho nagira pulmonary edema, nayigera it is a sign of overhydration. Of course hari imiti ushaka kumuha akagabanuka mu bihaha, ariko you never know, bishobora no kwanga akicwa niyo pulmonary edema. So dehydration itself, it kills also. Umuntu afite amazi make mu mubiri, it can kill very quickly. That's why abanga ubibonye uhita umuha perfusion. And there is edema, which we will discuss more here. So you know that 60% of our body weight is composed of just water, and most of this water is intracellular, meaning it is inside the cell, while the extracellular fluid is just 1/3 of all the water. Now, when we go into the extracellular fluids, just 5% is within the blood vessels and the lymphatics. Birumvikana ko amaraso muzi ko munagira umuntu mukuru volume 4 or 5 liters of blood bitewe n'ibiro afite, nuba ko ni 5% kandi mazi yose umuntu afite. So andi ni interstitial, ubu hari handi hagati ya fibers, hagati ya cells and so on, niho abayireba. In a normal situation, there is exchange of fluid between the vascular and the interstitial compartment. This exchange happens at the capillary level, but because you know our vessels, they are ntabwo zishobora kunyuramo amazi icyo ari cyo cyose, gusa amazi n'ibindi bishobora gutambuka muri capillaries, ariko raja veins ntabwo ikintu gishobora gutambuka muri wo unless there is a trauma, an injury. So normally there is no net gate or loss of fluid in normal situation. So habari balance. So lymphatic drainage plays a part in maintaining this equilibrium. So maybe you have seen this in the physiology, the function of the lymphatics. So lymphatics zikora nka veins, ariko zashyiriweho iki, Imana yaziheza kubera ko hari amazi atava muri interstitial tissue ngo yinjire muri yinjire muri veins azamuka. Ayo uretse amazi harimo n'ibindi bintu nka dead tissue debris, ya maserire amwe na amwe arwana, ntabwo ashobora kugaruka muri veins, ahubwo byinjira muri lymphatics. Otherwise lymphatics nazo zigira za valves nk'uko twabiganije. So there are two types of forces which drive the normal fluids between in veins and the arteries. Lymphatics here ngirango ni ibintu twavuga bigenda nk'uko veins zigenda, donc ni hydrostatic pressure, no, oncotic pressure, osmotic pressure n'ibitero. So these two forces are hydrostatic pressure. So muri make hydrostatic pressure, you must understand it as what? Hydrostatic pressure ni pressure iba imbere muri vascular lumen ibishaka gusunikira the content of the blood vessel kujya hanze. No kuvuga ni pressure irimo imbere ishaka ko ibintu biri muri lumen bisohoka bikajya hanze. So it is considered as a positive pressure. Ugiye muri bya positive and negative forces. Positive because it pushes. While the oncotic pressure or osmotic pressure, it is a pressure inside the lumen of a vessel which attracts things which are outside to come inside. So yo irakurura ntabwo isunika. So kweri kurura, it has a negative sign, So they are derived by what? Hydrostatic pressure y'ubwayo iterwa ubundi na pressure umutima wateranye amaraso. Niba umutima utera cyane, hydrostatic pressure n'ubundi irazamuka cyane. Ariko umutima iyo uteye, imbaraga wateranye zishobora gushirira mu nzira. Niyo mpamvu uburyo atari zacu ziremye harimo elastic fibers zituma za mbaraga umutima wateranye zikomeza kuba propagated until the arterioles, can say so. Nubwo wenda bigabanuka ho gatoya, ariko iyo pressure iba igihari yaturutse ku mutima. Iyi rero iterwa na cardiac output, vessel elasticity. When a vessel is no longer elastic, it becomes a problem. Vascular tone, if the tone is lost, it is a problem. Niyo mpamvu umuntu uri muri shock ukeka ko yagize tone y'umutima n'iya vessel zamanutse, umuha adrenaline kugira ngo tone izamuke, hydrostatic pressure yongera izamuke. Ikindi ni blood volume. When the blood volume is very low, the hydrostatic pressure will fall, will be reduced. So oncotic pressure nta kindi kiranga ni proteins, albumin. Niba albumin ari nkeya mu maraso, ntabwo hazabaho za mbaraga zikurura, cyane cyane tugeze kuri venular end, kugira ngo ibintu byari byagiye hanze gutunga amaserire ibisigaye bigaruke muri vein. Iyo bitagarutse rero biguma handi hanze. So nibyo turi bubone mu ndwara zimwe na zimwe tujya tubona impamvu umuntu ufite albumin nkeya agira idima, impamvu agira fluid, ugasanga byimbye amatama, abandi bakwashiyorko. So mushaka kumva impamvu kwashiyorko akindi kintu bitera albumin iri hasi, hydrostatic pressure yagombye gukura ya fluid yagiye muri interstitial tissue ngo igaruke muri vein, ntabwo igihagije, therefore fluid irigumira hanze. Kuko proteins zagomba kwikurura ntizihari, nigumira hanze idima. So zasanga ari abantu babyimbye amatama, amaguru, inda, so kwashiyorko as we know it. So coming back, hydrostatic pressure, it is a force which pushes the blood to go outside, while the choroid pressure is the pressure which attracts the fluid which is outside of a blood vessel to come inside the blood vessel. So normally, uko umuntu muzima yagombye kugenda bite? Kuri venular end, hydrostatic pressure yagombye kuba ntoya ugereranyije na choroid pressure. So choroid pressure yagombye kuba nini kugira ngo as a result negative force nihura na positive force the resultant ibe negative. Kugira ngo ibe negative nuko choroid pressure iba nyinshi. So tugero udafite proteine zihagije ngo iyi choroid pressure irusha imbaraga hangaha hydrostatic pressure n'ibyari biri hano kugira ngo ahubwo ngo bisangwe n'ibindi ahubwo nabyo birisongera bikagenda aribyo bakorana bakwashora uko n'abandi. So nanone hydrostatic pressure nimanuka cyane wene umuntu yatakaje amaraso cyane umutima nturi guterana imbaraga nabwo bizatuma iba nto cyane ku buryo even at this end ahubwo choroid pressure ishobora kuba nini ku buryo n'ibintu biri hano ahubwo byinjira aho kugira ngo n'amaraso yari hano bwayasohoka. So consequence murazumva nuko niba amaraso yari afite oxygen agomba gusohoka hanze ntasohoke ahubwo ibyanduye bikinjirira hanga muri arterial end. You understand that tissues which are here will not receive oxygen and nutrients. Nabyo bisobanura kwa kundi brain izatangira kuya brain death, acute tubular necrosis of the kidney, necrosis in the liver and so on. So hari imibare abantu banditse kugira ngo babisobanure neza. I hope you can see the screen. Yes, because there's a message here saying that the share screen is paused.
The screen is
okay. So here we have a capillary, arterial end, and venular end. Venular end here. So hydrostatic pressure here is plus 36. Plus it means positive. It pushes. Oncotic pressure is the minus 26. It's negative because it attracts. So as a result, you have a plus 10, meaning that at the end here, at the arterial end here, we have a positive pressure. Therefore, the blood will leave the vessel and go outside. So, nivuga blood ntumve para blood cells, ni fluids, proteins, and other nutrients. When we arrive at the venular end, you see that the hydrostatic pressure is plus 16, but the oncotic pressure or osmotic pressure is minus 26. Which means now the resultant will be negative. Being negative means now things which are outside will be attracted to come inside a vessel. Ahangaha niho rero ibintu byari biri hanze ya amadeshe yavuye ku maserire azagarakanwa n'amaraso akinjira muri veins, then akoherezwa mu mutima n'ibiha akongera agahabwa indi oxygen. Birumvikana azaba yahuye n'izindi nutrients zazamutse ziva muri liver zivuye muri intestines, so akagenda gutya. So nuko umuntu aremye. Ahangaha we have a reabsorption, while here we have a leak-out. This is in normal condition. So any disturbance here, you understand, if there is too much hydrostatic pressure is influence ku buryo nahangaho ngaho izaba ikiri hejuru. Therefore, blood, these debris or waste will not come back. Niba oncotic pressure ari nto cyane is the same, ntishobora kuba nini cyane gusa, ni gake cyane umuntu ashobora kuba protein nyinshi. Proteins are highly regulated, so ntabwo ushobora kuba ngo umuntu afite proteins nyinshi keretse muri tissues locally, ariko mu maraso no, keretse arizo wamuteye. Ariko zira zizamukira ziva muri intestines zifite uburyo umubiri ziregulating, ntabwo zishobora kuba nyinshi. So ikibazo nuko zishobora kuba nkeya gusa. But maybe exception, there are abnormal proteins can be produced by cancers. The cancer produce abnormal proteins. Zishobora kuba nyinshi ariko ntabwo zijya zibamo albumin, kuko albumin ni igenga oncotic pressure. So then you understand now the pathomechanism behind the edema. There is an increase in water in the interstitial compartment of the extracellular space, and there are many mechanisms. Both increase hydrostatic pressure or decrease in oncotic pressure. So hari amaterime menshi akoreshwa, hari hydrothorax mu gihe umuntu afite